Good evening, everyone. I hope I'm audible and visible to all of you. Just take a quick confirmation in the chat box so that we can quickly start off the session. So, very good evening, Dr. Pankaj. Thank you for confirming and welcome to this session. I'm Dr. Jazeer, your dermatology faculty at PW Meded. So today, as all of you know, that it's again a very important session. It's about the NEET PG PYQ series. So all the previous year questions. So we'll be discussing quite a few number of questions today. And the importance of this session, it's not required to be emphasized anymore because all of you know that the more the previous year questions that you practice, you get to know about what are the commonly repeated topics and what are the commonly asked areas from dermatology, right? So thank you all for responding, and without much delay, let's start our session now. Okay, so let's begin with the first question. The first question is the PYQ, which came as a match the following, where you have to match a disease with the type of scaling that is seen, like pityriasis rosea, pityriasis versicolor, psoriasis, pityriasis lichenoides. On the right hand side, you can see that everything is about scaling. So what would be your usual approach whenever you see these kind of a question is just go for that disease which you know very well. Like let's say psoriasis, most of you would be able to know, isn't it? You must have learned about psoriasis. In psoriasis, what is the kind of scaling that you have learned? You must have learned about silvery white scaling, right? So let me try to match 3 with A. So when I look into the options now, just when I match one of them, it is easily possible for me to rule out at least two options, right? So what are the options that you have ruled out? So 3A doesn't match with this, doesn't match with this. So now we are left with option A and B. So now let's see another one. Which one do you would like to go for? Is it pityriasis rosea or pityriasis versicolor? Yeah, so Dr. Debaki is saying rosea will have collarette scaling. So one is D. So let's see the options. Unfortunately, when you see the option, 1D is the same. That is in option A and option B. So which means we have to go for the next one as well. So what is the type of scaling you see in pityriasis versicolor? So is it Mica-like scaling or Branny scaling? So versicolor, Branny, fine rice powder like scaling, right? So option 2 should be matching with C. So 2 should go for C. So what is the correct answer now? The correct answer here becomes option A, right? Option A. So the importance of this kind of an MCQ is that whichever diseases that you have learned in dermatology, especially when you are going to appear for an exam very soon, what you have to do is remember the disease and the type of scaling. Okay, the disease and type of scaling. So psoriasis, silvery white scaling, pityriasis rosea, cigarette paper or collarette of scales, pityriasis versicolor, rice powder or a Branny scaling, and some other diseases also which you would know like lichen planus can have a Wickham striae, etc. So if that is clear, so now let's go to the next question now. So another question here is the image given below depicts the characteristic skin finding that can be observed in a juvenile dermatomyositis. So this is saying that a patient is having the juvenile dermatomyositis. And what do you see in this image? Is it a Gottron's papule? Is it photosensitivity, nail bed capillaries, or a malar rash? So very easily we can rule out malar rash because we don't see anything over the face, because malar rash is seen in SLE, right? It is seen in SLE as a butterfly kind of a rash. Now, when I just zoom this image for you, what do I find here is all these joints are being involved, and the area in between the joints, all this area, it is going to be spared, right? So what is this typical finding? So some of you are answering it as A. I mean, most of you are answering it as A. So someone is about B. So the correct answer should be Gottron's papules. So remember, in Gottran's papules, the knuckles, the joints, all these would have some kind of a patch or a plaque lesion. So whenever you see an image like this, when all the joint spaces or the knuckles are involved, this is called as a Gottran's papule, very typical for dermatomyositis. Moving to the next question. A pregnant female who was started on treatment for leprosy was found to have a type 2 lepra reaction. What would be the next line of management in this patient? So what brings my attention here is the patient is pregnant and the patient was on treatment for leprosy, and now the patient has got type 2 lepra reaction. Please correlate it accordingly. Now let's see the options. Thalidomide, stop leprosy drugs and start steroids. Continue anti-leprosy drugs and add steroids. Thalidomide plus steroids. What should be the answer? Now, if you have learned pharmacology, you would have seen that there is one drug which is mentioned here, which is definitely teratogenic. So what is that? So wherever I see that name, I can easily rule out that option. Yes. So I can rule out thalidomide wherever it has come, because in pharma, did you learn what is the side effect of this drug? Because it is teratogenic. Yes, very good, Shalu. Yeah. So what is the side effect? The side effect is that the babies, they can be born with sealed limbs, isn't it? They can be born with the sealed limbs, and this is called as phecomelia. Very excellent. So Tushar, Sangeeta, Dr. Depaki, Pankaj, all of you are answering. Anushri is also answering. So this can lead to phecomelia. Very good. So a baby can be born with the sealed limbs. So we have ruled out two options. Now we have two options in front of you. Should we continue anti-leprosy treatment or should we stop anti-leprosy treatment? Because adding steroids is there common for both. So will you continue? Yeah, will you stop? Yes, you will be continuing it. So here the correct answer should be continue anti-leprosy treatments and add steroids. Excellent. The way all of you are answering, excellent. So now let's see the next question. A patient was found to have a whitish lesion in the upper limbs and also in the penile shaft. So there is a lesion somewhere in the upper limb, and also there are lesions in the penis, right, in the shaft of the penis. So the most probable diagnosis would be, the options are scabies, lichen scrofulosorum, lichen nitidus, and lichen planus. So what do I see here is, if I just zoom this image for you, I can see that there are multiple small pinpointed papules which is seen over probably over the elbow region, right? So over the elbow region you can see multiple pinpointed papules. So what is it going to match with? Is it scabies? Because scabies, all of you know, it should be something like a burrows, right? So I don't think that this can be seen in scabies. Lichen scrofulosorum is something that we can see in association with, let's say, leprosy, or with tuberculosis of the skin, but it doesn't appear like this. So what is the right answer here? Yeah, Dr. Depaki is saying that it is asymptomatic most often. Very good. So the correct answer here should be lichen nitidus. And I also got a very good finding by Shivi in the chat box, because when you excise a part of the skin in a patient who is having lichen nitidus, so it gives you an appearance something like this. Suppose it's a ball. So this is the claw clutching the ball appearance, right? So yes, the claw clutching the ball appearance, and this is seen in lichen nitidus. So excellent. So that is another MCQ which was asked in one of the NEET PG exam. So now let's go to the another one. A 30-year-old male was admitted with vesicular lesions which were distributed in the chest over a single dermatome and also had complaints of pain. So they have given you all the options here. It's such an easy question that was asked. That is why I always tell you that dermatology is a very easily scoring subject, be it for NEET PG or FMG, isn't it? So here we have a single dermatome. The patient is having pain and you can see vesicular lesions in the chest. Now, what is the diagnosis? Excellent. The diagnosis is herpes zoster. So as all of you know, it is a reactivation of the, so this is going to be a reactivation of varicella virus. The reactivation of the varicella virus, which causes chickenpox. So after several years down the line, when the patient will develop these kind of lesions, and for me, the most important finding is this one. A single dermatome is involved and the patient is complaining of a burning pain, because the patient may complain like somebody has lighted fire over the skin. So the right answer here should be herpes zoster. Thank you so much for responding in the chat box. So now let's keep going now. A 65-year-old patient presented with a tense bulla which settled down after some time. What will be the most probable diagnosis? Now again, they're asking you regarding the diagnosis, but for me, when I read the question, this is the most catchy part. Patient is having a tense bulla, and every time you are going to deal with a question on vesiculobullous disease, always pay attention to the age as well. So once we pay attention to the age, it's an elderly patient, tense bulla. Now see the options. Dermatitis herpetiformis. IgA should not be pemphigoid. It is going to be IgA pemphigus. That was a clerical error. Pemphigus vulgaris and bullous pemphigoid. How many of you can answer this? So yes, many of you are answering it as G. Excellent, very good. Now what makes you answer it as bullous pemphigoid? Because in dermatitis herpet, let us try to rule out as well. Okay, let's see how whether we are able to do that or not. In dermatitis herpetiformis, the reason why I can easily rule out dermatitis herpetiformis is because there is no bulla. So there is no bulla which will be seen in this disease called dermatitis herpetiformis, because the patient will only have papules and vesicles, itchy papulovesicles. Okay? Yes, Dr. Deepak is saying it is associated with bro, all those things. Excellent. Now, IgA pemphigus and pemphigus vulgaris, if I just bring them together as pemphigus group of diseases, why is that not the right answer? Anybody in the chat box, can you just give me reasons why this is not the right answer? Quickly. So we have a lot of questions to discuss, so we don't have much time for each question. Excellent. So what is the answer that I got in the option here in the chat box is yes, because in both these cases we would be seeing a flaccid bulla. Excellent. So if there is no flaccid bulla, then what happens? It is going to be a tense bulla. Tense bulla means we always think about bullous pemphigoid. We always think about bullous pemphigoid. And of course, this bullous pemphigoid is also seen in, more commonly seen in elderly patients as well. So that is also helping us to reach out to this diagnosis. Amazing. So Sankita is saying that in pemphigus vulgaris, Nikolsky is positive. That is also right. I completely agree with you. In all the pemphigus group of diseases, it can be Nikolsky positive. Good. So now let's see another question. So this question says a 62-year-old male presented to the OPD with the finding as seen in the image below. He was a non-hypertensive patient with a history of atrial fibrillation. His current medications include atenolol, captopril, aspirin, and amiodarone. What is the most probable diagnosis? So in the meanwhile, Dr. Debaki, I'll get back to your answer in a while after we discuss this question. Okay. So is it captopril toxicity? Is it silver toxicity? Is it lupus pernio or amiodarone induced skin disease? Very good. So Sindhu is giving me a very specific answer because it is amiodarone, the blue man syndrome. Excellent. So this one, which is called as a blue man syndrome. So what happens in a patient who is taking amiodarone as a drug eruption or as a drug side effect, the patient's skin may turn blue in color. So this is due to amiodarone induced skin lesion. Whereas anything that matches very closely is a lupus pernio. So what is lupus pernio? Is that is seen in a chronic type of a sarcoidosis, isn't it? So where again the patient may have a violaceous or a blue color over the skin. But here, based on the history of the patient, since the patient has been taking amiodarone in his medications, the right answer should be the blue man syndrome that is associated. So yes, just like blue man, so Pankaj is saying that it reminds him of red man syndrome. So as all of you know, when you go for an infusion, a quick infusion of vancomycin, then what happens? Especially the upper part of the trunk may turn red in color. So here, that's a good point to be noted because vancomycin can lead to a red man syndrome. Can lead to a red man syndrome. Great. Very good. So one of the questions that I can see in the chat box is what is the most common target for bullous pemphigoid? So please remember, in cases of a patient with bullous pemphigoid, the most common target is going to be bullous pemphigoid antigen 2. BPAG2 more than BPAG1, which can be seen beneath the epidermis, that is in the basement membrane zone. Clear? So yes, gray baby syndrome, chloramphenicol. So I'm getting more and more answers here in the chat box. Excellent. So now let's go to the next question. On examination, a child was found to have an itchy and scaly bald patch. Which among the following investigations would be required? Now, I believe that this is a bit tricky question because it is a very non-specific question. If you have a good clinical thinking, you'll be able to answer. But when you see the options, it's much more easier. Is it a GMSA? Is it biopsy? Is it a KOH mount or a skin slit smear? So I'm so glad to see a lot of correct answers in the chat box here. Excellent thinking, good clinicians. So this should be a KOH mount, right? Because the reason is whenever you're dealing with a child who is having a bald patch, so in children, you know that this condition called tinea capitis is very common in children, right? So whenever you find this tinea capitis, any signs of a itchy and a scaly scalp in a child, so we are not directly jumping into any biopsy. We don't do a skin slit smear and all. So here the best answer should be a KOH mount because we suspect tinea capitis. Can anybody tell me like in which disease are we going to do this investigation which is called as a skin slit smear? Any idea? Any like in which condition do we do a skin slit smear? Anyone quickly in the chat box, please. So which condition do we do a skin slit smear? Excellent. So this is an investigation which we will do in leprosy. Okay, if you remember leprosy, when we just give a small slit in the skin and we try to see how much is a bacterial load when you examine under a microscope, that is how we do this investigation in the cases of suspected cases of leprosy. Very good. So now let's go to the next question. A 12-year-old boy, scaly lesions were observed in the cubital fossa, popliteal fossa, and also in the neck. These lesions were exudative and itchy. What would be the most probable diagnosis? And you can see in the image that there is some flexural region that is being shown. So is it something which we can suspect as psoriasis, atopic dermatitis, dermatitis herpetiformis, or erythroderma? What is your thinking about this question? Yes, once again, I'm getting the right answers here. See, always remember, this is a child, okay, who is having a scaly lesion and these lesions are itchy as well. So once I go option by option, psoriasis is usually not itchy, it is not itchy. Whereas dermatitis herpetiformis can be itchy, but this is usually seen in the extensor surfaces. Whereas psoriasis is also seen in the extensor surfaces usually. Erythroderma means the entire body should turn red in color, and that is easily ruled out because that does not match what we see in those options. So here the right answer should be atopic dermatitis, because in atopic dermatitis, remember, in any patient between 2 years to adults, we see lesions over the flexures. We see the lesions over the flexural areas, and this is a good case of atopic dermatitis. The case of atopic dermatitis. So now let's go to the another question. A patient was found to have painful vesicles on the genital region. Which among the following can be observed in a histopathological examination? So here patient is having vesicles, and that too painful vesicles in the genitalia. So whenever you see a question of a painful vesicles in genitalia, first tell me what is the diagnosis. Then let's go into histopathological examination. So imagine you got a patient. The patient is having vesicles in genitalia. The patient says it's painful. Tell me the diagnosis first. So in the chat box, many of you are answering it as herpes. I guess all of you agree to that. So this can be a case of herpes genitalis, where we can see there is vesicles in the genitalia. So in a case of herpes genitalis, which is caused due to HSV2 in most of the cases, what is a histopathological examination? Do you find HP bodies, that is Henderson-Peterson bodies? Yes. So here what happens is Henderson-Peterson bodies, they can always be seen in a disease called molluscum contagiosum, isn't it? They can be seen in molluscum contagiosum. So right now many of you are answering it as multinucleated giant cells. Okay. So what is the right answer here? Yeah. Is it Zhang cells? So this question may not be completely accurate, right? So what happens in the Zhang cells is that these are acantholytic cells or Zhang cells. Coilocytes, where do you find coilocytes? Human papilloma virus infections, right? So in HPV, which causes warts, you can find coilocytes. So the nearest best answer, what you can expect here is a Zhang cell. So here the nearest best answer, what you can expect here is a Zhang cell. Moving to the next one, a patient presented with a patch on the neck region and in the mandible that is associated with the presence of leukotrichia. Okay. It is associated with leukotrichia. The most probable diagnosis. So now here the examiner has not given us a diagnosis, right? The examiner has not given us a diagnosis, or they have not given us an image as well. What are the options? So we have to imagine that there is a patch in the neck along with the mandible, and you have to imagine that all those beard hair or something is also affected with white color. That is why there is going to be called as a leukotrichia. Does it match with nevus depigmentosus, pybaldism, Hansen disease, or vitiligo? Excellent. So here this matches with vitiligo, because nevus depigmentosus is a pigmentary defect, but in pigmentary defect you don't expect a leukotrichia. Pybaldism is an autosomal dominant condition where a patient can have a white forelock and vitiligo-like lesions in the body. Hansen disease means this is another name for leprosy. So here the single best answer should be a vitiligo. Should be a vitiligo. So what type of disease is vitiligo? Anyone? What type of disease is vitiligo? So yes, this is going to be a autoimmune disease. So it is going to be a autoimmune disease. Sindhu says like Indira Gandhi. So what is that disease where you can compare it with Indira Gandhi? Yes, that is going to be piebaldism, right? The white forelock. Very good. So now let's go to the next one. In patients with allergic contact dermatitis, allergic contact dermatitis means ACD. What would be the investigation of choice? See, very direct questions that has been asked in NEET PG exams. So what is the investigation of choice in ACD, contact dermatitis? Is it IgE radioimmunosorbent testing, patch testing, radioallergosorbent testing? Yes, so all of you are answering it again, right? This is going to be a patch test. So whenever you see that a patient has developed an eczematous rash, especially after being in contact with something, then we always suspect the diagnosis as a contact dermatitis. So in such cases, we do this investigation called patch test, where you take a reading. Are we going to take a reading immediately, or are we going to send this patient back home so that we can take the reading after some time? What is the right answer here? Excellent. The reading is usually taken after 48 hours. And even Sai Shri, Sindhu, all of you are saying that the reading is taken after 96 hours with best. Mishra, Arpit, Tejesh, all of you, very good. So the best reading can be taken after 96 hours, which means with maximum delay, Excellent. So now let's see another question. From the image given below, the type of skin lesion will be. So it's a very non-specific image that is given. So what I can see is I can just draw something like this over the image. And now let's see the option. Verrucous, annular, targetoid, discoid. What should be your answer? See, verrucous means it should be having a rough surface, isn't it? It should be having a rough surface, or let's say in another word, warty. So this lesion does not look like a warty type. Annular means it should have a round surface, right? Targetoid. So what do you mean by targetoid? Targetoid means it may have a round surface but something in the center. That is why it is like called as a target lesion. And discoid, see, discoid, you can take it in two ways. Discoid, sometimes if you take it as an eczema, it can be a discoid eczema, nummular eczema, where you can have a coin-shaped lesion, or discoid lupus erythematosus. So in discoid lupus erythematosus and all, discoid type of lesion means there can be a central atrophy surrounded by hyperpigmentation. Like in cases of discoid lupus erythematosus, DLE. So here, when you see all these options now, so what do you think is the most accurate answer? Because you may get confused between option B and D, annular and discoid. So for me, this should actually go in favor of annular lesions. It should go in favor of annular lesions. So because discoid lupus erythematosus and all, you will be seeing a different type of a lesion. But again, if you consider this as eczema, again the thought process can also go in favor of discoid eczema or nummular eczema as well. Clear? So that is why sometimes the MCQs can be tricky. So it all depends upon your thought process, right? So now let's go to the next question. Which among the following will cause painful ulcers on the tip of the glands? See, now if you are able to analyze the kind of questions that is being asked, ulcers is again a repeat question. That is the inference that you should draw from all these PYQs. So now let's see the options. Where do you find painful genital ulcers? So is it LGV? Is it Treponema pallidum, HSV, gonorrhea? Now remember, in always during our sessions, in our classes, what we discuss is pain less ulcers we use a mnemonic that is LSD, right? A drug LSD, painless ulcer. L stands for LGV, S stands for syphilis, and D stands for donovenosis. So all these are going to be painless ulcers. So which means chlamydia or LGV is going to be painless. Treponema pallidum, which is a causative of syphilis, is again going to be painless. Gonorrhea. Does gonorrhea cause any kind of an ulcer? No. So gonorrhea can also only cause genital discharge disease. Okay, not ulcers, not ulcers. So hence we can rule out this one as well. So what is the right answer here? It should be herpes simplex virus, which causes herpes genitalis. It causes herpes genitalis. So whenever you go and solve any of the MCQs, please try to apply the logic that you have learned so that you will be confident after answering that, okay, this is what you have got it right as well. Yeah. So now let's go to the next question. From the image given below, identify the correct statement on the condition. I hope all of you are with me. So let's do this answer now. Identify the correct statement. So if you have to identify the right statement, what should be our diagnosis here? So let's keep one or two differential diagnoses here. So what are the differential diagnoses that comes to your mind when you see this? Dr. Debaki says herpes labialis. Chalo, theek hai. Herpes labialis can be one of the differential diagnoses. Anybody else? Any other differential diagnosis that comes to your mind when you see this? Yeah, very good. Arpit Mishra, very good. This can also be impetigo, right? Because of yellow crusting and all that we can see. Excellent. So let's keep one bacterial infection, one viral infection in our differential diagnosis. So this one I'll just write it as differential diagnosis. And now let's take it logically. Zank smear to be done. So identify the correct statement. Zank smear, yes, because we can do Zank smear in cases of HSV, that is herpes labialis. So let's keep it aside. Gram negative cocci can be seen. So in case this was, impetigo, will we see a gram negative cocci or a gram positive cocci, isn't it? So it can be gram positive cocci. So here this can be gram positive, so that we can rule it out. Next one is central umbilication will be seen. Central umbilication in which disease have you seen this? So in which disease can we see central umbilication? Yeah, it can be seen in molluscum contagiosum, right? So very good. So molluscum contagiosum is also not the answer. And Pun cells can be seen. So where do you find these Pun cells? Like this Pun cells, also known as the Greenblatt and Pun cells. This can be seen in granuloma inguinale, right? So in donovenosis and all. So that definitely is not matching. This is also not matching because this is going to be seen in molluscum contagiosum. So now what should be the right answer? The right answer should be the Zank smear. The right answer should be the Zank smear. And what do you see in a Zank smear usually in the cases of HSV? In the case of HSV, in a Zank smear, we can see a multinucleated giant cells. See multinucleated giant cells. So moving to the next question now. A patient was found to have a subepidermal blister along with neutrophils positioned at the tips of the dermal papillae. Which among the following would be the treatment of choice? So come on, let's see who gets it right. So here what I see is a patient is having a subepidermal blister, which means the blister is below the epidermis and there are neutrophils at the tip of the dermal papillae. Now, the diagnosis here, what can be the diagnosis here? Anyone? Dermal papillae neutrophils can be seen. Excellent. So Sindhu, Sankita, Depaki, all of you are answering it. Sai Shri, excellent. So here the right answer, the diagnosis is dermatitis herpetiformis. So the right answer is dermatitis herpetiformis. So in case of dermatitis herpetiformis, these kind of neutrophils that you see below the epidermis near the dermal papillae, what do we call it as? Is there any name or how do we mention it? So these are neutrophilic microabscess, right? Which we can see near the dermal papillae. So here the diagnosis should be dermatitis herpetiformis. And how do we treat them? Do we treat them with cyclosporin, rituximab, dapsone or azathioprine? Yes. So this should be treated with dapsone. So Saurav is answering. Very good. The Saurav, Naman, all of you are answering it right. So here this is also called as the papillary tip microabscess. It is also called as the papillary tip microabscess. It is an example of neutrophilic microabscess. And the drug of choice here should be dapsone. And many of you are answering it as gluten sensitive enteropathy, celiac disease. I absolutely agree with all of you because this disease is closely associated with celiac sprue. It is associated with celiac sprue. So now let's go to the next one. Exclamation mark sign is seen in which of the following conditions? So where do you see an exclamation mark sign? Exclamation mark is something like this, right? So in which disease do you find them? So when you see the options, alopecia areata, tinea capitis, trichotillomania, androgenic alopecia. So we understand that this is a finding that is seen in the hair, right? So this is seen in the hair. And now let's be more specific. कहाँ पे? Alopecia areata, tinea capitis, trichotillomania, androgenic alopecia, and I'm waiting for your answer in the chat box. Yes, so the chat box is all filled with AAA. So yes, so here the right answer is alopecia areata. So this alopecia areata, which is also a autoimmune disease. So in this disease, we can see that under trichoscopy, when you see under a microscope, you can see that the hair, which is far from the scalp, they have become much more broader. So this has become much more broader. And the hair that is closer to the scalp, they have become much thinner. And that is why we compare it as a exclamation mark, isn't it? Please explain anagen effluvium and telogen effluvium. Okay. So there is one question on anagen effluvium and telogen effluvium. So I'll just take a couple of minutes to tell you the difference between both. All of you know that anagen hair means that is the growth phase of the hair, and telogen hair means that is the resting phase of the hair. So whenever there is a increased shedding of anagen hair, that is called as anagen effluvium, and whenever there is a increased shedding of telogen hair, we call it as telogen effluvium. So just try to remember that whenever you are seeing a patient who is undergoing a chemotherapy or radiation or radiotherapy, then what happens? The chemotherapeutic agents or in radiotherapy, what happens? They are going to attack the active phase of the hair, that is the anagen phase, because of which there is an anagen arrest, and all these hair would be shifted to the telogen phase, and hence there will be a lot of hair fall. That is called as anagen effluvium. Whereas telogen effluvium is always associated with stress, and a lot of examples of stress that we know, like it can be exam stress, it can be a stress due to an infection, it can be a stress due to a recent surgery or anemia, pregnancy. So whenever there is a stress associated, the increased hair fall is going to be elogen effluvium. So is that clear? So now let's go to the next one. A patient presents with below skin lesion in which there is no mucosal involvement. Which of the following organism will be the most probable cause? So what I see here is, I can see that there is a erythema in the lesion, and in the central part there is something like a bulla which has been ruptured now. So what I can see is that there would be a bullous lesion which has now eroded, and there is some erythema as well. So what could be the diagnosis here? If anybody could think it on a clinical aspect and could make out some differential diagnosis or diagnosis. Yes, so this can be an example of a bullous impetigo. It can be a bullous impetigo. So now let's see what could be the answer here. Which organism? Is it a gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli? So based on the diagnosis of a bullous impetigo, what could be the answer? Yeah, gram-positive cocci. Gram-positive cocci. Because impetigo can be caused by either staphylococcus or by streptococcus. So in both the case, the answer can be a gram-positive cocci. Done. So now let's go to the next question. The next question is, a lady with bilateral buccal involvement having a lacy white pattern which is not able to be scraped by a spatula. Pain increases on intake of spicy food. No history of tobacco chewing, but the patient is having a history of dental amalgam on the third molar tooth. What is the likely diagnosis? So we are talking about something that is seen within the oral mucosa, and in the oral mucosa there is a white lacy pattern, and the patient is complaining that he is having a pain every time he may consume a pickle or a spicy food, isn't it? So what is the diagnosis? Lichen planus, erythroplakia, leukoplakia, candida. Yes. So why many of you are coming for an answer like lichen planus? Because this white lacy pattern that you can see, this is called as Wickham's striae. And these kind of finding that you can see in this disease called lichen planus is very important, because this is a pre-malignant lesion. It's a pre-malignant lesion. And this is going to be pre-malignant to squamous cell carcinoma as well. It is going to be pre-malignant to squamous cell carcinoma. So erythroplakia, definitely not, because here the question itself is saying that it is a white color lesion. So it's not going to be red color lesion. Leukoplakia, again, what we see, anything in white can be leukoplakia, but the question is more specific for lichen planus. Candida, what can be done is, when you use a spatula and all, these candidal whitish discoloration, it can be easily scraped off as well, right? So here the right answer should be lichen planus. So let's go to the next question. Old man with a depigmented vertical patch on the lower jaw, neck and sternum. The rest of the physical examination is normal. So why did the examiner use this word vertical patch? Okay, vertical patch. Vertical means something like this. So which is going to affect the jaws and the neck and the sternum. So what comes to your mind? Segmental vitiligo, acrofacial vitiligo, pybaldism, albinism. Very good. So as all of you are answering it right in the chat box, so I also completely agree with you. It can be a case of a segmental vitiligo, because this is another case which follows dermatomal distribution. It also follows a dermatomal distribution. And all the other choices, acrofacial means the face as well as the extremities can be involved. Piebaldism we discussed. White forelock is not mentioned here. Albinism will have a generalized depigmentation. So the best answer here is a segmental type of a vitiligo. Yeah, Sindhu, in the cases of vitiligo, as you asked for different types, vitiligo can be of different types. It can be focal vitiligo, where you find only one or two lesions anywhere in the body, isn't it? Another type of vitiligo is what we discussed now, that is going to be segmental, which is going to be over the dermatomes, over a dermatomal distribution. Another type of vitiligo, which we can see in the option itself, is acrofacial. So acrofacial means, acral means extremities, and facial means face is involved. Okay, the face and the extremities are involved is acrofacial. The most common type of vitiligo, it can be vitiligo vulgaris, okay, where you get symmetrical lesions. So symmetrical because if you have a lesion here, there would be a lesion on the opposite side as well. So symmetrical lesions can be also be seen. And the last one, rare type but severe autoimmunity, which is called as vitiligo universalis, where more than 90% of the body surface area becomes depigmented. Where more than 90% of the body surface area becomes depigmented. So these are the different types of vitiligo. These are the different types of vitiligo. Yes, doctors community says that facial, lip tip, all is having a poor prognosis. I completely agree with you. Okay? Now let's see the next one. One lady developed painless, beefy red genital ulcer with a swelling in the inguinal area. On biopsy, safety pin appearance was noted. Which of the following is the most probable diagnosis? So where in microbiology did you learn about something like this, a safety pin appearance, and the patient is having painless ulcer which is beefy red in color as well? Granuloma inguinale, lymphogranuloma venerum, syphilis, chancroid. Who can give me the right answer? A lot of you are saying it as option A. So why do you say it as option A? Because granuloma inguinale, it is the old name of this disease. And what is the better name for this disease called granuloma inguinale? Yeah, this is called as donovanosis. It is called as donovanosis. And what do you call for this closed safety pin appearance? Yeah, this closed safety pin appearance, it is having a specific name as well. It is called as Donovan bodies, right? Donovan body. So here the right answer should be granuloma inguinale or donovanosis, where there is the patient can present with a red, beefy red ulcer which can bleed to touch as well. So now let's move to the next one. A farmer comes to the skin OPD with a painful swollen foot which has discharging sinus, dark grains coming out of it. So when I read this question itself, I can clearly see a triad of some disease. So what is that? Is it botryomicosis? Is it Madura foot, actinomycetoma, or sporotrichosis? Yes, excellent. So here the right answer should be Madura foot, which we also called as mycetoma, right? So there is something called as a mycetoma triad. So in this triad, as you would remember, there would be a swollen ankle or a swollen soft tissue swelling. Along with that, there would be a discharging sinus and there would be some characteristic grains. So this one sentence has added all the triad of mycetoma. The correct answer should be Madura foot. Correct answer should be Madura foot. So now let's see the next one. Botrytis in Staphylococcus aureus, actinomycetoma, because actino plus nocardia both. Yes, Dr. Depaki, completely agree with you. So the next question is, a patient came with complaints of diarrhea, dermatitis, mental retardation, and the patient was found to be a maize eater. If all of you were able to answer a medium level difficulty to a highly difficult question, this would be an easy question for you, right? So what is the answer here? Beriberi, night blindness, pellagra, kwashiorkor. So this one, yes. So 4 Ds of pellagra, right? Diarrhea, dermatitis, dementia, death. So here, the correct answer should be pellagra. And also one of the clue for you is that the patient is a maize eater as well. So let's see the next question. All are seen in this condition except. So if I just see this image, if I zoom this image, so since I'm having a habit of always describing a lesion whenever I see them, I can see that there is some flat topped papules as well as plaque lesions, and the color for me is not red. The color for me is purple or violaceous, right? So yes, Shalu Raghav is also adding it to it, right? So here, what we can see here is, uh, since it is a purple colored plaque lesion or papules that I can see, the diagnosis or the differential diagnosis that should come to my mind should be a lichen planus. So now let's see the options. Monroe microabscess, Wickham striae, sawtooth acanthosis, cavity bodies. So if any one of you is unable to make out a differential diagnosis from the image, even reading out the options can also help you to reach the diagnosis, because 3 of the findings here is associated with one disease. Kyunki Wickham striae, sawtooth acanthosis, cavity bodies, all these are seen in lichen planus. So the odd one out is Monroe microabscess. Can anybody tell me where do you find a Monroe microabscess? Some pathology, histopathology finding. The clue for you is a neutrophilic microabscess which can be seen in the stratum corneum. Yes, excellent. So this is seen in psoriasis. So this can be seen in psoriasis. Very good. So let's go to the next one. Which of the following is a side effect of 13-cis retinoic acid? Teratogenic neural tube defect, follicular hyperkeratosis, photoonycholysis. Now first we have to think why this question, that too in dermatology, because the question looks like it is something in pharma. Now this 13-cis retinoic acid is another name for retinoids, right? Like isotretinoin and all, isn't it? So what is isotretinoin? Isotretinoin, that is something that we use in a disease called acne vulgaris, pimples, right? So what is the side effect? The side effect is teratogenicity. And in case for the next exam, if they ask you what is a teratogenicity period or teratogenic period for this drug, what should be your answer? Your answer should be yes. It should be 1 month. It should be 1 month. So no, whoever is answering it as 3 years, please note down that 3 years is a wrong answer. So 3 years is actually for acitretin. It is another retinoid that is called acitretin, which is used in pustular psoriasis. Clear? So please don't answer it as 3 years. 3 years, remember, it is acitretin and that is used in pustular psoriasis. 13-cis retinoic acid is actually isotretinoin. Yeah. So now let's go to the next one. Yes. A patient presented with hypopigmented macules over the back and the upper trunk. On KOH mount, spaghetti and meatball appearance was seen. What can be the causative agent? So a lot of you are answering it as A. Chalo. Why A is the answer? Option A. Hypopigmented macules are seen over the back and the upper trunk. So these are hypopigmentation, which I can see. Spaghetti and meatball appearance was seen. So here, what is the diagnosis? The diagnosis should be pityriasis versicolor or tinea versicolor. So in those cases, it can be caused due to malassezia furfur or malassezia globosa. So here, the right answer should be malassezia furfur. And Saishri is adding a very important thing, that malassezia globosa is more common than malassezia furfur. I agree with you. Thank you. So malassezia globosa is more common than malassezia furfur. Next question. A patient presented with lesions as shown in the image. Later, the patient also developed arthritis. What's the treatment? When I see the image, I can see that there is a red color plaque and there is some whitish scales over it. So, पहले diagnosis बताओ. What's the diagnosis? Yeah, the diagnosis here, it looks a very typical image. So this looks like psoriasis. So when a patient is having psoriasis and when the patient is also developing some joint pains, and that is arthritis, will you go for methotrexate, cyclophosphamide, mycophenolate or rituximab? Yes. So here, remember, the overall drug of choice in psoriasis is going to be a drug called methotrexate, right? So even if the patient is having psoriatic lesions over the trunk along with joint pains, that is arthritis, the answer should still be methotrexate. And cyclophosphamide, mycophenolate, all those things can also be used as a systemic agent. And but we usually don't use rituximab in psoriasis. So any idea in which disease in dermatology are we using rituximab, MAB, monoclonal antibody? Now, in which disease do we use it? Any idea? Are you able to recollect rituximab anywhere in dermatology? So that was in pemphigus group of diseases. So that is in pemphigus group of diseases, okay, which I mean in dermatology. So now let's go to the next question. Identify the plant that is shown in the image. So now, leaving all the skin conditions behind, now we got an image of a plant, and that is also asked under dermatology. So what is it? So this is a plant which grows everywhere, isn't it? This is called as a congress weed. So what is it? Yes. So this is called as the Parthenium hysterophorus. Hysterophorus. So why this plant is very important for us? The reason why it is important is because this plant is going to be the most common cause of allergic contact dermatitis. It is the most common cause of allergic contact dermatitis. Hence, this plant is important for you to identify. I'll just zoom this image for you. And this is called as Parthenium hysterophorus. The next one is clinical signs, that is Auspitz sign. See, all of you, whenever you are going to do a MCQ on clinical signs, remember, try to map all those clinical signs of diseases, because whenever you get a question on signs, it is going to be a straightforward question. So Auspitz sign, where do you find them? Pemphigus, psoriasis, pustula psoriasis, acne vulgaris. So I'm getting a mixed answer. Some few of you are saying B for box. Some of you are saying A. So what is the right answer? Auspitz sign, remember, it is seen in psoriasis vulgaris because pin pointed bleeding spots on scraping the lesions. So when we take a glass slide in a patient who is having psoriasis, when we try to scrape over the lesions, what happens? You can see some pinpointed bleeding spots, and that is called as Auspit sign, which is seen in psoriasis vulgaris. I'm not sure why many of you thought about pemphigus vulgaris, because in pemphigus vulgaris, I would say that you can see Nikolsky sign positive. Like when you apply a tangential pressure over the skin may get peeled off. So that is why Nikolsky sign may be positive, but it is good na ki in the chat box people are competing with each other. Nice. Okay, nice. So now let's go to the next question. First line treatment for acne comedones. So whenever you get a patient who is having a comedonal acne can be two types. Like it can be either blackheads or whiteheads. So whenever you have a patient who is having a blackhead or a whitehead, what are you going to use? Are you going to use a topical steroid? Are you going to apply some topical antibiotics like clindamycin? Or would you like to go for a benzyl peroxide or a topical retinoids? Excellent. So whoever is answering it as topical retinoids, please remember this is the first line agent in comedonal acne. So it's a first line agent in comedonal acne. And it is also very important that before you go for your exam, please remember some of the examples of topical retinoids. Okay. So what is the example of a topical retinoid? The examples are adapalene. Okay. Remember some names: adapalene or retinoin. Adapalene and tretinoin. So these are examples of topical retinoids as well. Excellent. So now let's go to the next question. Identify the condition that is shown. See, it's a pretty direct question. You were given an image and you were asked to make out the diagnosis here. So when I examine this lesion, I can see that in the central part there is a dark pigmentation. There is a lighter pigmentation over the remaining part of the lesion. So what is it more likely to be? Malignant melanoma, basal cell carcinoma, squamous cell carcinoma, or is it some kind of a nevus? So yes, so all these atypical characteristics, this is going to match with malignant melanoma, because whenever we see a mole, we always evaluate it with ABCDE algorithm, right? Asymmetry of the lesion, border irregularity, color variation, diameter more than 6 diameter. So for me here, color variation is seen. Diameter is obviously more than 6 because it's more than 0.6 centimeter and it is an evolving lesion. Hence, the right answer should be malignant melanoma. Which organism is responsible for causing erysipelas? So this question, even if you categorize it under microbiology or under dermatology, still fine. But tell me if you have learned what is the organism which causes erysipelas. Is it Streptococcus, Staphylococcus, Bacteroides, or a fungus? Remember, erysipelas is exclusively caused by Streptococcus. Hence, the right answer should be option A. It is going to be Streptococcus. What is a common complication that is associated with the following condition? So here once again you can see around the lips or in the face, and the color that comes to your mind directly when you see this lesion is a yellow crusting, isn't it? So in which disease do you see a yellow crusting? Yellow crusting can be seen in cases of impetigo. Which impetigo? Non-bullous impetigo. So in cases of non-bullous impetigo, what is the complication that is associated? Post-streptococcal glomerulonephritis, staphylococcal scalded skin syndrome, encephalitis, pneumonitis. Yes. So here what happens, remember, non-bullous impetigo, which is also called as impetigo contagiosum, in this cases, Streptococcus is more common than Staphylococcus. Streptococcus is more common, right? So if Streptococcus is more common, the right answer should be post-streptococcal glomerulonephritis, which can be caused as a complication of this condition, mostly in non-treated cases, right? Very good. So now moving to the next question. A patient presents with a history of severe sunburn only after few minutes in the sun, which means there is photosensitivity. There is freckling in sun exposed area. So freckling means some brownish discoloration that can be seen in sun exposed area. There is a dry skin and changes in pigmentation. Xeroderma pigmentosum, Bloom syndrome, warts, melanocytic nevus. So what is the right answer here? So from the name, from the entire history itself, what is matching most likely? Xeroderma. Xeroderma means dry skin. And pigmentosum. Pigmentosum usually means hyperpigmentation. So here the right answer, yeah, many of you are answering nucleotide excision repair defect. Yes, very good. So this is going to be Xeroderma pigmentosum. And how is it acquired? Is it X-linked? Is it autosomal dominant? Autosomal recessive? So how is it acquired? Yes. So this is going to be a autosomal recessive condition as well. It can be a autosomal recessive condition as well. Excellent. Happy that all of you are able to answer. Next question. Child presents with sores in the mouth and a rash on the hands and feet. What is the causative organism? So when there is a child who is having some lesions in the mouth, in the hand and feet, obviously based on this clinical scenario, the diagnosis should be, yeah, why all of you are answering it as A? Because you have understood that it is going to be hand, foot, mouth disease, right? HFMD. And what is the most common organism that causes HFMD? It should be a virus, and the name is Coxsackie virus A16. Excellent. I hope all of you is getting it right. Next one, a child presents with fever and a pleomorphic rash. Now, where did you learn about the pleomorphic rash? Pleomorphic rash means that all stages of the rash is seen in the patient at the same time. So is it seen in chickenpox, smallpox, measles or rubella? Yes. So pleomorphic means you think about varicella virus and the correct answer should be chickenpox. The correct answer should be chickenpox. So in the chat box, you guys are using smileys as well. Nice. Next one, a truck driver with non-pruritic lesion all over the body, including the palms. So what is the most probable diagnosis? The patient is having non-pruritic lesion. Non-pruritic means non-itchy lesion all over the body. And the patient is having a hyperpigmented lesion over the palms as well. So is it a viral exanthem or secondary syphilis, toxic epidermal necrolysis, or a drug eruption? So a lot of answers in favor of B, that is secondary syphilis. So why secondary syphilis? Because in secondary syphilis, these hyperpigmentation that you see over the palms and soles, that is going to be very specific for secondary syphilis. And it could have been a viral exanthem only if there was a mention of fever, isn't it? And there is no mention of any drug that was used, and the clinical scenario does not match toxic epidermal necrolysis as well. Some questions in the chat box. Yes, truck driver is a history given, so we always suspect about a sexually transmitted infection as well. Drug eruption usually on lips, sir? No. Drug eruption, yes, sometimes over the shaft of the penis, over the lips, all these things can be seen. But here, truck driver, lesions over the body and the palms, all is in favor of secondary syphilis. Now, the next question, identify the condition that is shown in the image. Rhinophyma, rhinoscleroma, rosacea, acne vulgaris. So, what is more likely, isn't it? You can see that, yes. So, this one also most of you are getting it right. Kyunki यहाँ पे, this is also called as a potato nose. It is also called as potato nose. And the right answer should be rhinophyma, isn't it? Phymatous type. So even though rosacea is given as one of the option, rhinophyma is more accurate when you scale it, isn't it? So this is going to be rhinophyma, where there is a sebaceous gland hypertrophy. Sebaceous gland hypertrophy. Identify the psoriatic nail change that is shown in the image. Oil drop sign, Auspitz sign, subungual hyperkeratosis, Koebner phenomenon. Who can get this one right? So there is a patient of psoriasis and this is a psoriatic nail change. So when I see the image, what I can see is that there is a thickness beneath the nails. So there is beneath the nails means subungual, thickness is increased means hyperkeratosis. So this is the right answer. Now here, I guess all of these things are seen in psoriasis क्योंकि oil drop sign can be seen, Auspitz sign today we discussed, subungual hyperkeratosis is the image what you can see, and Koebner's phenomenon can also be seen in psoriasis, right? Yes, oil drop when it comes to the nails, whereas oil drop cataract is galactosemia. Agreed. Oil drop is also called as salmon patch in the nails. All correct. Okay. Now let's go to the next question. Identify. So identify, there are options are given: Darrier sign, Auspitz sign, dermographism, Koebner phenomenon. And what you see in this image, if you want, I can just zoom this image as well. So it looks like a patient has scratched over the skin. After scratching over the skin, the patient has developed a linear plaque lesion in over the skin. So what is this going to be? Yes, when a patient develops new skin lesions because of trauma, it's called as a Koebner phenomenon. It's called as a Koebner phenomenon. Now let's quickly see what are the options here. In which disease can we see a Darrier sign? Anyone? Darrier sign can be seen in, yes, Darrier sign. Anyone? 2 more seconds. I shall wait. Many of you are answering about Koebner, which I agree is right. Yeah. Darrier sign, very good. Cutaneous mastocytosis, says Sai Shri Balakrishnan. Yes, this is seen in urticaria pigmentosa. Pigmentosa, or it's an example of Darrier sign, ye yaad hai sir. Okay. Cutaneous mastocytosis, Shaurya, all of you are answering. John is also answering. So that is Darrier sign is seen in urticaria pigmentosa. Auspitz sign, we had already discussed, that is seen in psoriasis. Dermographism. Where do you see dermographism? Dermographism, it can be either red or white, which is more common. So red dermographism can be seen in a condition called as chronic urticaria, whereas white dermographism, yes, Arpit, can be seen in atopic dermatitis. Can be seen in atopic dermatitis. Whereas Koebner phenomenon, this Koebner phenomenon can be seen in three diseases, that is LVP. Do you remember what are the three diseases? This can be seen in lichen planus, vitiligo, as well as in psoriasis. It can be seen in lichen planus, vitiligo, as well as in psoriasis. Okay? Okay. And before we go to the next question, since we have seen Kobner here, what if in the next exam they may ask you about pseudo Kobner? So just note down pseudo Kobner as well. Let's note down pseudo Kobner as well. So can you tell me in which disease do you find pseudocobner? I already have the answers in the chat box. Yes, it can be seen in molluscum contagiosum as well as in viral warts. Excellent. So it's an amazing batch. All of you are answering it, and I'm glad to see that all of you are able to recall whatever you have learned in dermatology. Now let's see the next question. Patient is having no history of fever. Well, the examiner started in that way. No history of fever in the past. Developed nodular lesions over the face. Identify the condition. So this is the image for you. Multiple nodules can be seen over the face. Is it erythema nodosum? Is it post-Kala-Azar? Dermal leishmaniasis? Leprosy? Cutaneous leishmaniasis? Yes, very good. So I guess everyone is getting it right. The correct answer is leprosy. So we all have learned various clinical classification of leprosy. So based on this image, which type of leprosy do you think that this patient is having? Is it a tuberculoid type? Is it a borderline type or a lepromatous type? Yes, so this looks like a lepromatous leprosy, isn't it? It looks like a lepromatous leprosy. Excellent. Super. So moving to the next question, the shown lesions are. So here there is an image-based question. It should be a spot diagnosis, right? So you can see that the patient is having multiple papules, but there is some typical finding here because every papule is having a depression here in the center. So this central depression or central umbilication should raise a suspicion of molluscum, chickenpox, pemphigus, common warts. What is it? Yes, it should be molluscum contagiosum. And the scavenger says Henderson Peterson bodies. Very good. Henderson Peterson bodies as well. Excellent. Now, next one. The following lesion was noticed in an obese patient. What's the diagnosis? Well, from the image, it is difficult to say which part of the skin or the body it can be. But what I can see here is there is a rough lesion and the skin looks velvety. There is a hyperpigmentation as well. And the question says that this is an obese patient. Now, acanthosis, laser trilat, actinic keratosis, intertriginous candida. What should be the answer? Yes, so this looks like acanthosis nigricans. One of the common area where you can find them is in the nape of the neck. It can also be seen over the axilla. It's most common in obesity and can be associated with a lot of diseases, including metabolic syndromes, polycystic ovarian disease, etc. Isn't it? So that is about acanthosis nigricans. Yeah, Heron syndrome. So what is laser trilat? See, laser trilat sign, just wrote here. Laser trilat sign means whenever a patient will develop multiple seborrheic keratosis lesions over the trunk. So when a patient will develop a lot of seborrheic keratosis lesions over the trunk, this can be an indicator of GI adenocarcinoma. That is called as laser trilat sign. That is called as laser trilat sign. Okay. I hope that is clear. Fine. So now let's go to the next one. Drug of choice for syphilis. Easy question. They're talking about syphilis. Are you going to treat it with ceftriaxone, erythromycin, tetracycline, or benzathine penicillin? Yes, very good. So here what you can do is you can go for benzathine penicillin shots, isn't it? And that is considered to be the drug of choice in the cases of penicillin. Is it 24? Yeah, 2.4, because I can see somebody mentioning 24 IU. So is it 24? Yeah, 2.4 million units. Yes, it should be 2.4 million units, right? Good. Excellent. Fordyce spots involves. That's the next question. This can be under physiology or you can consider it under dermatology. So where do you see Fordyce spots? It is something that you can see over the lips or it can be seen over the genitalia, etc. And is it a sweat gland? Is it a mucus gland? It's a sebaceous gland or mole glands? Okay. Too many wrong answers now. Sometimes the easiest question may get you wrong, right? And that will leave you with a lot of disappointment as well. So focus, don't make silly mistakes. It's absolutely all right to make silly mistakes today, but not on the day of the exam. So think, what is a Fordyce spot? Fordyce spots, these are ectopic sebaceous glands, because of which a patient can come to you with some whitish spots over the lips or some whitish spots over the genitalia. Correct? So this one is going to be sebaceous gland. So it's okay to make mistakes. It's all fine. But remember, Fordyce spots is a disease of an, it's not a disease, it's just a condition of ectopic sebaceous glands. Now let's go to the next question. The shown image is a causative of. So there's a black and white image. It looks like a KOH finding and you can see that there is a large organism which looks like this. So is it scabies? Is it pediculosis, molluscum contagiosum, Pithris pubis? Yes. So here this is going to be scabies. Now all of you getting it right, because the organism what we can see here is called as Sarcoptes scabi, and this is the causative of scabies, isn't it? And the investigation that has been done here is a KOH test. It is a potassium hydroxide test where you can see this kind of an image. So yes, with that we have completed pretty much questions. And it was a 1.5 hour long session. And thank you so much for interacting. Fox Fordyce and Fordyce are different. Of course, yes, Fox Fordyce is going to be a ectopic sebaceous gland, whereas Fordyce is going to be an ectopic sebaceous gland. And what is Fordyce? And what is Fox Fordyce? Fox Fordyce means patient will come to you with the complaints of itching over the axillary region, and this one is going to be a disease of apocrine sweat glands. Yeah, I'll just note it down in the previous one. Fox Fordyce is a disease of apocrine sweat glands. And as you know, apocrine glands, they can be seen in the axilla. It can be seen over the over the groin area, over the areola and all. So usually what happens, a patient with Fox Fordyce disease, they come to you with a itchy axilla. They come to you with a itchy axilla. So thank you for being a very interactive crowd. And my inference as a faculty is that if you are able to recall all these things, if you are able to answer and also contribute with various other things that you have learned from each and every topic, your preparations are right on track. So please try to give the NEET PG predictor GT, which is live in the Meded app, and also make sure that you join the Sankalp NEET PG mentorship group in Telegram as well, because we have a good community of medicos and all the faculties together. And thank you, Harpit, for the comments. And thank you so much. And I wish you all the very best for the upcoming exams. I'm sure all of you are going to rock it. Thank you so much.